we have a couple of questions regarding the different BTK inhibitors and their respective values. And besides the three usual ones, also what could be the potential value of non-covalent inhibitors. Francesco, do you want to start with that?
Yeah, thank you, Gilles. Yeah, that's a very interesting field. Non-covalent appears to have to be active in some of the resistant BTK inhibitor cases in CLL and other lymphomas. Unfortunately, it seems that they have more side effects, or at least off-target effects, because they are not so specific as compared to first or second generation BTK inhibitors. But anyway, it represents a new tool for those patients that are resistant to BTK, so we can use them in such cases, except for those cases that have these BCL2 gamma mutations in the BTK pathway, where the BTK pathway is super active. Then it's not important to inhibit the BTK protein, not tyrosine kinase, because the pathway is going to be active anyway. So in those cases, it's not indicated to use this new non-covalent BTK inhibitors. But anyway, it's a new drug that we have, that probably they have some spot, some role in the BTK or venetoclax resistant cases.
Stephen, you really touched that very briefly regarding the activity of these drugs in mantle cell. Do you want to expand a little bit on that?
Yeah, I think the new BTK era will be quite challenging. I think the answer between which BTK is the best one will come probably from the CLL world, because there are more patients, and the ALPIN trial will be presented by Gilles, I think, in this Congress. Will probably answer to some questions. And in mantle cell, whether or not we will observe a difference will be difficult to build in a phase 3 trial. What we know is there may be differences, at least in terms of side effects, which is also important, is to see less side effects, at least cardiac side effects, with the new generation of BTK. Within the LOXO one, where it's very active, including in some ibrutinib-resistant patients, which is highly interesting. So their capacity to be less toxic and more active will be challenging. And the other point will be how to combine this agent with other agents. Is this easier to combine ibrutinib, for example, with venetoclax, or LOXO with another BCL2? And that's another very complex question. Is not only the efficacy by itself of each BTK, but also its ability to be combined with other drugs in a biologically-driven way. So for sure, there might be some difference. And another thing is the price, right? So we also like to think about the price of the BTK inhibitor, and for small difference, we need to pay more or less. That's an interesting question. But Zanu, LOXO, that will be a long question for a lot of ICML meetings, I think.
Well, thank you, both of you, for your answer. I think we can take the first poll question, which is a little bit more related to this field. So if we can have the first slide or the first question. So yes, so I think I read the question again for everybody. The question is, well, I have a little bit of a hard time to see it. Oh, and we have already the answer, it seems. Awesome.
Pretty impressive.
Okay, well, the question basically was related to the OASIS regimen that was mentioned by Dr. Gilles, and the question was what were the combinations that were assessed during this regimen? And I think the answer is ibrutinib, venetoclax, and obinutuzumab, if I read correctly what has been written. I know there are other triplets being evaluated, so that's a Boven regimen here in MSK and some other centers in the US, but basically it's the same kind of strategy. Coming back to the question, are there any comments regarding this BTK from all the colleagues?
I just want to say I'm not responsible for the question. I'm not the one who asked this question.
We have a couple of questions regarding follicular lymphoma that came up that you may want to address, Loretta. Probably one of the interesting questions, which was raised by our colleague Astrid Pawlowski, is we do see some patients with follicular lymphoma that have received immunochemotherapy in the first-line setting, and that may progress at 1.5 years or so with a small tumor volume. And she's asking whether this patient really need treatment, is watch and wait remain an option, and whether or not we should really intervene for this patient if they obviously don't have any insight regarding a potential transformation.
I think that's a really good question. I think I didn't cover that in my session, but for patients who are of low tumor burden, I generally think it's still appropriate to observe. I would ensure that we've excluded transformed disease in that setting, because again, these patients, even if it's low tumor burden, if it's aggressive disease, you want to treat it immediately. But if you've excluded the possibility of transformed disease, I generally will still follow the Gilles criteria when I decide when to initiate therapy, even for these early relapse patients.
Yeah, well, I agree with you. I think we should not rush for this patient, but obviously it's debatable for the different patients, the different presentation and things like that. But that brings us probably to the second question that was related to your presentation, which was raised by some of our colleagues, which is, do you feel that really the new agents that are available, the combination of obinutuzumab with benda for those who had a benda naive, or the other agents, are really displacing the role of autologous or allergenic transplant in follicular lymphoma?
I don't think as of right now. Now, the thing I'll say about autologous stem cell transplant, if we consider the retrospective nature, but the CIBMTR analysis that Carla Casulo led and Tony Smith was involved in, if you apply auto transplant within 12 months of that early progression event, those patients tend to do quite well. If you apply it later than 12 months, then really they don't do any different than those patients who don't have transplant. So I think you should still consider transplant, consider early in the disease course, but if you miss that window, meaning if the patients are making their way into an academic center after they've already had 2 lines of therapy, then in those cases, I am quick to move into novel therapy. On this slide, you see the PI3 kinase inhibitors, and I did not discuss them today because they're really reserved, in my opinion, to the third line or later space, mostly because they're continuous therapy and the toxicity can be somewhat unpredictable. So again, the benefit of an auto transplant, it's a one-time therapy. I think the question will be whether or not CAR T replaces transplant altogether in that second line space, and those studies are underway right now.
So you were mentioning transplant, allergenic transplant. Do you think it still has a role in our field of follicular lymphoma?
I think it will be exceedingly rarely used, though there are still centers like ours, and we plan to look at that because I do think you can cure patients with allo transplant. Again, they're going to be young, fit patients without significant comorbidities, but I don't think we should throw it out altogether. I just suspect it will be rarely utilized.
Yeah, I think I concur with your comments. I should pay also a little bit of cautions regarding the early relapse in patients that are from registries in which we don't have a biopsy at the time of relapse, and we show the benefit of transplant, but it may also include some patients that have some disease. Actually, Stephen, we published that several years ago also. Coming back actually to the field of mantle cell lymphoma, we have a lot of questions about transplantation, Stephen. And it seems like in this disease, the role of allergenic transplantation is still a question that is challenging, and in the first line setting of patients with P53 mutation. And somebody asked whether you had some regret in the way you have managed your patients initially, whether you will recommend a first line allergenic transplant for patients with P53 mutation and young patients.
Well, today, if you look at recommendation, international guidelines, autologous stem cell transplantation is standard of care frontline for transplant eligible patients, regardless p53 status. And nothing today has been shown to be better than this approach. The problem is with p53 is not black and white. Some p53 mutated patients don't do that bad, including with transplant. And there is a UK trial where patients were allotransplanted frontline. This is work published by Salles, but the conditioning regimen was alemtuzumab based, and so very TD-plated treatment, and there were a lot of relapse. I think it's controversial, but my feeling is that today, going to allotransplant first line because of the p53 status, it cannot really be recommended outside of clinical trial. So I don't have any regrets for these patients. Sorry if they relapse, but there's no other way today to manage these patients. I think the fact that he has a p53 status should be a warning for the clinicians to carefully follow this patient, look at, if possible, at MRD status to offer new treatment. And for me, I think the options today will not be the allotransplant. It will be the ibrutinib-based bridge, maybe to a CAR T. That will be, I think, more attractive than an allotransplant based on what has been published about the CAR T cell resulting in mantle cell lymphoma. So today, first, to answer your question, no, I don't think we can go to the allotransplant frontline, but I know some of my colleagues will support this approach. And I will probably challenge allotransplant at relapse by the use of CAR T.
I think I will follow on with some other questions regarding mantle cell lymphoma. And somebody mentioned the trial, which is called Mantle First, which is a comparison of chemotherapy, which is probably the back regimen with Ara-C-Benda combination and rituximab versus a BTK inhibitor, showing kind of no major differences in patients with relapse after 12 months, if I recall the publication. Do you think this may lead you to reconsider the use of BTK inhibitor in the relapse setting, or do you think that we should really move forward and keep this second line chemo regimen for very difficult to treat patients? So I don't know for which one anymore.
This is an interesting trial that showed that after 1 year, if you relapse 1 year after time diagnosis, then you do better if you receive ibrutinib rather than a chemotherapy. But beyond these limits of 12 months, there is no major differences between bendamustine-based regimen versus ibrutinib. However, it's always better to take a pill rather than to go to the hospital to receive chemotherapy. So with the equal efficacy, the use of ibrutinib is probably the winner as compared to a chemotherapy. In this group of patients, most of them will relapse. If the patient is in CR with ibrutinib, with a well-tolerated drug, it's always challenging to stop the drug and switch to another treatment. However, if the patient is only in PR, that makes sense not to wait too much before to go to another option. And this option here for me, I will not repeat what I said previously, will be CAR T. So the idea is to use the BTK as a bridge for the CAR T for highly refractory patients, in particular if they're p53 mutated or blastoid variant, or those with a complex karyotype. So this is a very interesting finding, good information for late relapse. For early relapse, there is a room for new treatment for sure.
So we have a couple of questions that I will try to bring together to the group with the different diseases. But I think we have a few questions more related to the DLBCL field for you, Andy. And they are related to the sequencing of a CD19-directed therapy. And you alluded to that, and you show a slide showing that I think it was with loncastuximab, it didn't prevent the activity of CAR T. Do you think this is something worrisome beside CAR T, where it has been clearly described that in DLBCL, a fraction of patients, but not negligible, maybe 30% or so in some of the axi-cell study, relapse with the CD19 loss of expression, a biological phenomenon that is well known in ALL, obviously, where the CD19 relapse are even more frequent. So do you think this has some influence regarding the development of ADC such as Lonca, the next antibody tafasitamab that you mentioned, and CAR-T? Do you think we should be thinking that one should be used before the other or vice versa?
I think that's a really good and important question. And of course, I don't think I know the answer to that. As you have said, antigen escape is one of the mechanisms of action of failure of CAR T cells. And although the CD19 target is a really good target and generally has been stable, we recognize it can be lost at the time of progression. So I showed a little bit of data. I'm sure the slide was very small, but it suggested that those patients who'd had previous exposure to the anti-CD19 antibody drug conjugate Lonca-T could go on to have CAR T cell therapy, and there wasn't loss of CD19 antigen. We don't know that with tafasitamab. We don't have those biopsies that have been done at the time of progression. So I think it's really interesting. It's worrisome, but I don't think we clearly know the answer to this yet.
Yes, I think there was a question regarding CD19 loss after exposure to other CD19-directed therapies, and up to my knowledge, whether it's TAFA or whether it's the Lonca, it hasn't been described. So maybe with TAFA, the antigen masking that may lead to consider some washout period before the exposure of the antibody and the role of CAR-T. So I think we can have on the screen the second poll question, which is related to the treatment of patients with early relapse follicular lymphoma. And there is a choice between different options for this patient, and which one will be considered a viable treatment options for patients with early relapse follicular lymphoma. One of the PI3 kinase, lenalidomide rituximab, a clinical trial with CAR-T, all of the above, none of the above. I'll let you take time to answer, and during this time I will ask the faculty to comment on a question that comes in different ways, but basically address the same question, which is how are we thinking that CAR-T could displace really the different therapies? And maybe I will start with you, Francesc. You already touched upon that, but where do you see CAR-T coming in the field of management of CLL? Do you think that given the success of targeted agents, it will remain as it is now, I mean, clinical trial options, and even if the clinical trial show promising result, more late stage options? Or do you think that we have the same enthusiasm that we see in other diseases?
I think CAR-T raises a lot of enthusiasm at the beginning, but after maturing the data, the results so far are not as good as the ones we are seeing in mantle or follicular or diffuse large B-cell lymphoma. The hypothesis, probably the reason, is the allergic T-cell populations the CLL patients have due to the nature of the disease, plus the therapies we are giving to those patients, particularly purine analogs and so on. Therefore, I think there is a lot of room for improvement in CLL. Still, that's the reason it's still considered a very experimental therapy. And the number of trials of CAR-T in CLL is still, unfortunately, low. Some of them combining drugs that are putatively changing the T-cell allergy. So we'll see. Ibrutinib is one of the drugs that apparently is changing the T-cell repertoire in CLL. We have to improve that to move to the CAR-T early lines for the CLL.
Okay, I think just a little warning. I don't know if it's you or one of the other speakers may have this microphone touching the office or something like that and making some background noise. I think we can look at the result of the poll, and this will be a nice transition, to Loretta. Can we have the result of the poll? Okay, well, Loretta, basically the question is the same for you. Do you think that CAR-T will displace transplant? Do you think that we will have basically a competition between CAR-T and bispecifics? How do you see the field moving with these cellular therapies?
Yeah, I think clearly what we've seen with ZUMA-5 was 17 months of median follow-up and the median PFS has not been reached. It's very encouraging to me. And these were patients that were heavily pretreated and over half had POD 24. So where I see CAR-T and follicular lymphoma is those rapidly progressing patients that are blowing through multiple lines of therapy. Also, we have some patients that are clinically behaving like transformed disease. It's behaving very aggressively. So sometimes I biopsy them and I'm surprised that there's still follicular lymphoma on the biopsy. To me, those are the patients where I'm very enthusiastic about CAR-T. I also recognize that it's grossly underutilized in the US for large cell lymphoma, where most people think of it as curative intent. So I suspect it will be even more so underutilized in follicular lymphoma, speaking to the number of options that are available to patients. So I think it does fall on us to really carve out a clear path for which patients should be considered for CAR-T. I don't think bispecifics will really be a challenge. I think bispecifics will be taken up much faster and move into earlier lines of therapy. And so I suspect CAR-T will fall after the bispecifics in follicular lymphoma.
Yes, I think this is very interesting. So we don't have the result of the polls as a slide, but 2/3 of you answered yes for all of the above. So all the options will be available here. I may have one little comment on the field, and I think with CAR-T that potentially has a safety profile and more limited constraints than the initial CAR-T developed, and especially less neurological events. I think it can be also offered as a minute treatment for patients. And, you can get your leukapheresis, you don't need bridging, you don't have a high tumor volume, you get your CAR-Ts, you are treated in an ambulatory setting. Yes, you have cytopenia during 2 weeks, and then after you are quiet without treatment for a couple of months or years, but we don't have the long-term results of those. Stephen, you have already mentioned several times CAR-T and how they will potentially move the field. Any further comments?
I think mantle cell is somewhere between the indolent follicular lymphoma and the aggressive relapsed refractory DLBCL. So what have been highlighted by Loretta and by Andrew is true also in mantle cell on both sides. A relapsed mantle cell lymphoma with an early relapse are very aggressive disease. So I have no doubt that treatment like CAR-T is definitely one option, maybe bispecific as mentioned, but today we know much more about CAR-T in mantle cell than bispecific. And it's used in BTK failure, but tomorrow we're all sure that BTK will be used frontline. So all patients will be BTK failure at first relapse. So the competition between bispecific and CAR-T will be important, with the fact that the toxicity that is a challenge will be more acceptable in mantle cell lymphoma, where the patient die because of the disease progression, than in follicular lymphoma that is much more indolent and you have several options. So CAR-T is probably the most attractive treatment for very refractory patients, including those who relapse. But all patients have to be BTK refractory, I think, before to use CAR-T. Bispecific, it's still difficult to know, but we should also not forget about the combo of targeted therapy, doublet, triplet, whatever is your favorite combination, provide very interesting results too. And CAR-T in mantle cell, my experience, which is limited because we get early access to CAR-T in mantle cell only a few months ago in France, is a treatment that is quite toxic for mantle cell. I don't know if it will be a confirm in the coming years, but my feeling, I don't know what is yours, is that toxicity in MCL is quite challenging.
There is the same experience here, and it seems like the presently available CAR-T in the mantle cell field is accompanied with some difficult side effect to manage. There is a very small question, very short answer. do you think that CAR-T can be envisioned in mantle cell patients with CNS involvement, like it is for the LBCL?
Yes.
Yes.
Is that short enough?
Yeah, perfect. Andy, I think obviously you registered, I have to say that, yes, we registered our talk a few weeks ago, and we have heard recently that at least one of the randomized trial assessing cellular therapy with CAR-T in this particular trial is a Captagen Maralacel against autologous stem cell transplant in the second-line setting for patients with very specific characteristics, which were early relapse patients, will turn out positive for several endpoints. How do you think this is going to change the field?
So, CAR T cells are really important in terms of changing the therapeutic landscape in DLBCL. And clearly for a select group of patients in the third line setting, this is a really important modality. I think before we throw out the autologous stem cell transplant, we've got to really look carefully at this data, because I think, we probably, in terms of sequencing, we probably can't follow up a CAR T cell with an autologous stem cell transplant, whilst the other order we can deliver clearly very safely CAR T cells after failure of an autologous stem cell transplant. So we've got to see the granularity of the data. So of course what we've seen is simply a press release from the Transform study looking at Lysel against standard of care, and we know that it's met its primary endpoint at a second interim analysis. But we don't know anything more about that. And as you say, Gilles, this was just a specific group of patients who had refractory disease or relapse within 12 months of therapy. So I see the data really interesting. I see that we've got obviously another 2 randomized studies also to report with different CAR T cell products. But I think, here we've got a potential for a change in the therapeutic algorithm in DLBCL. So I think second line, I think that's very exciting. I think we're really interested in the study that looked at patients who had high risk features in the frontline setting, who looked like they were heading to failure because they presented with high IPI, they presented with poor risk biological features, and then they failed to resolve their ctDNA with R-CHOP chemotherapy, and then went on to have CAR T cells as a rescue in this kind of context of preventing refractory disease. I think that's really exciting. It's complicated. It may not be the right therapeutic approach, but I'm really interested in how we might use that. And I think clearly we know that CAR T cells have efficacy in people with secondary CNS disease, and that's a massive unmet need for our patients, because I think conventional chemotherapy doesn't serve that group of patients well. The other thing I wanted to say really was actually about that group that has relapsed disease, that sits in the middle between being not too frail to be ineligible for stem cell, for CAR Ts or stem cell transplant, and those groups who are clearly fit for conventional second line approaches. So we've got a group of patients who probably are not stem cell transplant fit, but probably are CAR T cell fit. And we can see from the range of comorbidities and the age ranges in some of the CAR T cell studies that actually it can safely be delivered to people who are older. And I think resolving the treatment pathway for those individuals, I think is going to be something that we're going to need to work through. But we look like some products certainly are safe in the older population.
So I think we have only a very limited time to conclude. We have a couple of questions that are interesting. The role of NGS in the routine practice, and I think it's not yet here for treatment decision except in selected patients, or whether you want to inventory p53 deletion. There is an interesting question regarding prior exposure to bendamustine with CAR-T, and you may eventually think to extend that to the field of bispecific in the future. And I was quite amazed to see that there are some charts which is delivered in the US regarding the use of CAR-T in mantle cell with previous exposures to bendamustine, with some unpublished data suggesting that the use of this drug in the 6 months prior to CAR-T was associated with lower response rate and shorter PFS. But I look forward to the scientific publication. So I give you really 20 seconds of what will be your favorite new agent for the future. Loretta, let's start with you.
I think the follicular specifically, we're looking at combination strategies, and I'm particularly excited about moving bispecific into an IMiD combination into earlier lines of therapy. So I think that will potentially be something to look forward to in the future.
Andy, what will be your most promising agent for the DLBCL field?
I of course, CAR T cells, but I'm really interested in the bispecific data. We need to know about the durability of response. But what I will say, in a very short number of years, we've seen the approval of 2 ADC constructs, and I think that's really quite interesting in terms of a therapeutic approach to this disease. So I'm looking forward to see the expansion of new targets with ADCs.
Stephen?
Well, to remain quite close to our routine practice, I think that mantle cells, the combination of targeted therapy, oral targeted therapy, as a challenge for tomorrow. CAR T, of course, but we already have very nice drug that we need to learn how to combine together, including frontline. So that's for me the major challenge today, and challenge autologous stem cell transplant.
Francesc?
Yeah, the same as Stephen, the combination of target therapies with different mechanisms of action. And finally, we're starting trials with biospecifics. So I'm looking forward to see these drugs in CLL.
So I think we are really arriving to the end of this symposium, and I will really like to thank my colleagues for their participation, for the excellent presentation, for the lively discussion, also all the attendees that came and raised many questions. Sorry, we didn't have time to take all the questions, neither actually all the poll questions, but I think this is a very emerging field, and I think that really we will continue to have interesting discussion in this setting of hard to approach or difficult to treat patients in the relapse setting. I would really like to thank also the supporter of this symposium in the occurrence Beijing and BMS, and obviously all the team of the Lymphoma Hub for having organized in collaboration with the organization in Lugano of the ICML. So please continue to follow up on us on Lymphoma Hub and on the website and on Twitter and so on. This is a platform where we exchange a lot of news regarding lymphoma, and we'll come with new activities enabling us to further discuss actually some of the topics we addressed today.